End-stage glaucoma is much more difficult to differentiate from non-glaucomatous optic neuropathy, and sometimes that is challenging even to the most expert. So what are we trying to distinguish glaucoma from? So the glaucoma mimickers could be something acquired or congenital. Acquired could be optic nerve or retina. The optic nerves could be something that is compressive in nature. It could be other things that are inflammatory, hereditary, ischemic, toxic, and traumatic. If it's compressive in nature, this is the one that we want to rule out an active compressive, of course, tumor, for example. And this is when there's visual loss, central loss, pallor, and all these things. The other listed here, the inflammatory, hereditary, ischemic, if you take a good history, you often will not miss those things. Retinal disease usually mimics glaucoma by way of visual field deficits. Vascular occlusions or previous vascular occlusions, retinitis pigmentosa, PRP, high myopia, and the congenital anomalies of the disc also can mimic a glaucomatous visual field. So look at the discs very carefully for tilted discs, clobomas and pits, hypoplasias, morning glories, megalopapilla, and often these are non-progressive in nature. Now, optic disc drusen can cause progressive optic neuropathy, and if you see any progression, of course, you need to image those patients. If you see pallor, you need to image those patients, even though they have these congenital disc anomalies. Some examples of congenital disc anomalies here, borrowed from Seminars of Ophthalmology, Glaucoma Mimickers paper. This here, on the left top side, is an inferior optic nerve coloboma, giving you that visual field deficit that looks glaucomatous. This here is an enlarged blind spot from a morning glory, which is, a blind spot is not really typical of glaucoma. This here is a superior segmental hypoplasia that's giving you those inferior visual field deficits. So then how do you approach the pseudoglaucoma suspect? We go back to our main history, exam, and investigations. So now that you have this list, always be thorough on your history. When you examine, of course, you're going to do an optic nerve head and retina exam, but I write it here because you have to do an intentional optic nerve head exam, looking for the congenital disc anomalies and looking for atypical features that may indicate that this is not glaucoma, such as pallor, for instance. And of course, look at the retina too, because sometimes we're too focused on the nerve and we kind of just screen through the retina very quickly. So look at the vessels. They could be attenuated in their retinopathy, and look at the rest of the retina, retinitis pigmentosa, PRPs, and so forth. When you investigate, of course, you're doing visual fields and OCTs, and add to your OCTs and OCT macula, as I mentioned, because sometimes remote vascular occlusions can only be diagnosed that way. So this is pretty much what I need to tell you today, but now we're going to take you through a series of live cases. So this is a 52-year-old gentleman who comes in with a very, very gradual loss of vision of the right eye to 20/50 over the past year. 20/25 in the left, there is loss of color vision on the right and the right RAPD. So right off the bat, this seems a bit odd for glaucoma. But if it's an end-stage glaucoma, it could be. The left asymptomatic eye looks like this. There's this inferior loss. And the right eye shows the superior and inferior losses peripherally, but there is a smack right in the middle of a secocentral scotoma. This is very atypical of glaucoma. So the first thing we want to rule out here is a compressive etiology. Now, looking at the optic nerves here is a little bit of asymmetry in the cupping, but the nerves otherwise look well. There is not really much pallor there. There's no other indications of glaucoma. So there's a mismatch between the optic nerve appearance and the visual field deficit, although asymmetry of the cupping can be happening in glaucoma as well. So we imaged this patient, and lo and behold, he had a huge meningioma compressing the optic nerves on the right and the left with this vasogenic edema. It's very important to recognize compressive etiologies, because if the patient has good thickness on the OCT, which this patient had, normal OCT RNFL and GCIPL, there's a good chance that we will recover the visual field deficit that has been lost. So this patient was admitted and he was resected, and visual fields returned back to normal. So early recognition of compressive optic neuropathy is very, very important, and it's important to tease out what is glaucoma and what is compressive if you had both. Cupping can be a result of compressive etiologies, compressive optic neuropathies. And the red flags to look for, and these are the specific red flags, in a young patient, central vision loss, pallor, the type of visual field defect, especially if there's a vertical respect. So always look at the visual fields both at the same time, because sometimes a bitemporal hemianopia is only seen by looking at both fields at the same time. Of course, asymmetry, when you see that the optic nerve head doesn't match the amount of visual field deficit and the type of nerve fiber bundle loss. If the MRI is reported normal, I often look at the internal carotid artery and see if it's compressing that optic nerve as well. There are some reported cases of compressive optic neuropathy from ICI compression. So just having a normal MRI with a patient who is progressing despite a normal IOP, you want to consider that as a possibility. We can talk about that later, but that's something to consider. Our next case is a 68-year-old female who has been having vision loss over the past month to counting finger vision and a left RAPD. Her IOP was 25 on the right, 28 on the left. When you look at this fundus photo, she looks quite glaucomatous on the left side with that inferior deep notch with a high cup to disc ratio, no pallor, nothing else really going on, and the right optic nerve looks good. The left visual field is completely dark, and so if this patient indeed has glaucoma, there must be something else that's going on, right? Unless it's a rapidly aggressive glaucoma, which is quite unusual. So this patient was investigated as a retrobulbar optic neuritis. She was checked for blood work, chest imaging, imaging of the brain, and she was also started on steroids, and she was quite refractory. She didn't improve, and no diagnosis was found at that time. She comes in 2 months later, and this happens in the right eye now. And so she's losing her vision to counting fingers over the past 2 months this time. So looking at the optic nerve here, it looks swollen, not like the first eye, right? And so this patient was investigated again for a possible retrobulbar optic neuritis that is atypical. So blood work was done, whole body scan was done, imaging was done of the brain, and no cause was found. Now, because this is a bilateral sequential optic neuropathy, despite the age of the patient, despite being a woman, she was also checked for Leber's hereditary optic neuropathy. And as it turns out, she was positive for Leber's hereditary optic neuropathy. She also had glaucoma, so she had both at the same time. She was left with NLP vision OU, unfortunately, with severely cupped nerves and loss of the ganglion cell layer. This is just to say that about 50% of Leber's can present with not the typical features, which is the pseudoedema and the telangiectasia, and so keeping that in mind is very, very important. In addition, Leber's can also heal with cupping as well. On the other hand, this is a 32-year-old man who is, minimally symptomatic, let's just put it that way. And he says that, he never had 20/20 vision since at least grade 2. His vision is 20/60 with no color vision. He has no RAPD. And he was investigated with an MRI orbits and brain with contrast, and no compressive etiology was found. His visual fields look nonspecific, and his optic nerves look like this. So there's a large cup to disc ratio, and there is temporal excavation of these optic nerves with a lot of pallor. There is loss of the RNFL, loss of the GCIPL. This is a typical case of dominant optic atrophy. And this patient tested for a positive for the OPA1 gene. Now, usually they come with central or secocentral scotomas. So these non-specific field deficits may indicate that this patient maybe has glaucoma on top of the DOA. So this patient has to be followed for progressive visual defect, because DOA should not progress. So hereditary optic neuropathies usually are bilateral, even if they're bilateral sequential in Leber's. They usually cause central visual loss, color vision loss, secocentral scotoma, and loss of the papillomacular bundle. And remember, if you face a patient who has a painless progressive optic neuropathy that is especially not responsive to steroid, even if the nerves look normal initially, then look for Leber's. Another case is a 66-year-old man with incidental finding of a visual field defect, as you can see here in the right eye, infranasal visual field defect, 20/20 vision, full color, with a small right RAPD. The OCT RNFL shows segmental loss corroborating with the visual field deficit, as well as the GCIPL OCT. So looking glaucomatous so far, but the right RAPD is telling us a little bit of something. Also, the optic nerves don't look glaucomatous whatsoever. In fact, they're elevated, but they're not swollen. There's a small cup to disc ratio. And if you look at the right optic nerve, there is temporal segmental pallor. They have scalloped edges, and this patient was a vasculopath. The patient had optic nerve heterusin, and we presumed that this patient had a NAION. Now, because this patient is incidental, and we need to image this patient, because if they gave us a history that is clearly like I woke up with inferior altitudinal visual field defect that is not progressive, then we would say, confidently that this was probably NAION. But because it's incidental, it's important to take a look and make sure it's not a compressive etiology. Also, it's important to follow up these patients because optic nerve head drusen can cause progressive optic neuropathy, in which case then you would give them IOP lowering medications. This is another case of an asymptomatic 51-year-old female who has binasal visual field deficits, glaucomatous looking OCT, RNFL, some segmental loss on that GCIPL. Again, the nerves don't look glaucomatous, but sometimes the nerves just don't. They kind of look tilted, very difficult to tell is this glaucoma or not. This patient had elevated optic nerves, but not swollen. The patient had optic nerve head drusen. So sometimes optic nerve head drusen can look like glaucoma, but I wouldn't jump to treat this patient right away because this patient may have had this visual field deficit all their life. It may never progress, so I won't commit them to IOP lowering medication just yet, but I will follow them up. And if they progress, then I will put them on an IOP lowering drug. This is a 74-year-old female who has these cupped-looking optic nerves. They are cupped, more so on the right than the left. There is pallor more on the right than the left. The patient has some inferior altitudinal defects corroborating OCT, RNFL, and GCIPL. Now, if you just see this case without asking a history, you may think this patient has glaucoma, but the patient tells us that she had a sudden bilateral inferior altitudinal visual field loss that is stable ever since. And if you look in the old charts, the patient had swelling with each episode of the optic nerve. So this is ischemic optic neuropathy that just healed with cupping. So it's important to ask about GCA and check for serology for GCA. And despite having no symptoms and a normal serology, the fact that it was bilateral and that the patient healed with cupping made me think that let's just do a temporal artery biopsy. And it was positive for giant cell arteritis. And what this is telling us is that AAION heals with cupping much more than NAION does. In fact, in a paper by Helen Danishmeyer, talks about AAION healing with cupping in 92% of the cases versus 2% in NAION. Now, visual acuity and color vision can be spared typically in NAION and atypically in AAION. So it can happen in both. So ask about the history, look at the old charts because it's important because sometimes that gives you the whole story, or at least part of the story. This is a 65-year-old lady, and if you look here, you can see that the nerves kind of looked cupped, maybe glaucomatous. There's temporal sloping, there's bearing of the circumlinear vessel. There's this inferior altitudinal visual field loss on the left eye, a little bit of a thinning on that OCT RNFL. Now, this patient had thinning of the inner macular, inner retinal layers, indicating a remote branch retinal artery occlusion. And sometimes these patients are completely asymptomatic. But it's very important to recognize because this is a stroke. So you have to send this patient to the stroke clinic for optimization of stroke risk factors. This patient was not asymptomatic. This patient was symptomatic. In fact, you can see in the left optic nerve here that she had a Hollenhorst plaque. You've all picked this up. So she had an inferior altitudinal visual field defect that was sudden onset. She was a vasculopath. And if you look at the big picture early on, she had a superior branch retinal artery occlusion on that left side with that Hollenhorst plaque. And she had edema of the inner layers of the macula with paracentral acute middle maculopathy there that you can see. We're almost done. This is a 25-year-old lady who comes in, and you can see that there's a little bit of more cupping on the right than the left. She has superior arcuate defect. This is borrowed from a paper of glaucoma mimickers. And if you look closely at the arterioles, you'll see that they are attenuated. And in fact, she had sectoral retinitis pigmentosa, which is really the reason she had these superior arcuate defects. So this is not glaucoma. It's a retinal cause for glaucoma. We talked about those. So the retinal causes of visual field deficits that can look like glaucoma would be something like remote vascular occlusions, RP, PRP. So look at the retina, look at your macular OCTs, and review the previous charts. So really the take home here is that glaucoma mimickers may be congenital or acquired. It may be an active process like a compressive pathology. It may be a remote process such as an old BRAO. You have to follow up your patients, even if you diagnose them with congenital disc anomalies. If there is pallor or if there's progression, do image those patients. And the imaging should be MRI orbits and brain with contrast. Glaucoma may be overlapping with other entities, and sometimes you actually find something on the imaging, but it's not always the cause. So you may want to ask your neuro-ophthalmologist friend to help you distinguish whether the lesion that is found on the imaging is actually causing a compressive optic neuropathy in order for the patient not to go for an unnecessary intervention, let's say if it's a benign incidental meningioma. Thank you.
Thank you, Dr. Dana. I would like to introduce Dr. Raed, who will be talking about update on optic neuritis.
Okay, thank you very much. Sorry. I have no financial interest. So, this is supposed to be an update about optic neuritis, and you're going to hear me talk about what's typical and what is atypical optic neuritis, because there has been some evolution in our understanding of optic neuritis over the last 20 to 30 years. And we know now that optic neuritis now, it's not a single disease, it's a multitude of different phenotypes. So what is a typical optic neuritis? It's a disease that presents with unilateral loss of vision, usually associated with pain with eye movement, and the visual acuity can be between 20 to 2000. And it responds to steroids, and what you would see if you obtain an MRI with these patients is the typical MS kind of lesions, and you probably would diagnose this patient as either optic neuritis as a clinically isolated syndrome, and you would probably consider referring this patient to a neurologist. Anything that deviates from this now, it's called atypical optic neuritis, and this can be a multitude of different diseases, including NMO, infectious, and other autoimmune disorders. So those of you who've trained at my age or probably older would know that all what we know about the treatment of optic neuritis now comes from the optic neuritis treatment trial. And this is the definitive trial that was done 30 years ago, and it gave us guidelines in terms of how to treat and how to investigate optic neuritis patients. So this trial was done like 30 years ago, and it really it applies to only those patients who have typical optic neuritis, that is optic neuritis associated with MS. However, the participants of that trial were predominantly young, white women. They were unilateral, and they excluded patients less than 18 years of age. Now, as far as the visual outcome of that study, what they found is that no matter if you treat, if you don't treat, the vision will always get better. And after 15 years, those who, 72% of optic neuritis patients had visual acuity of 20/20, and 66% had at least 20/20 in both eyes. So what they also found is that oral steroids were associated with increased risk of recurrence, and they were the study basically recommended not using oral steroids for treatment. And then, although IV steroids did not really improve the long-term visual outcome, they did give some kind of short-term benefit against the development of clinically definite multiple sclerosis. What about the risk of MS from optic neuritis? The long-term follow-up showed that the benefit that the IV steroids really only speeded the visual outcome, and the 15 years results showed that 72% of those patients who had at least one lesion, one brain MRI lesion, had a 72% risk of developing multiple sclerosis, and overall 50% of those patients on the study converted to MS. And this is just the results, 15-year results. So if you have the higher the burden of the lesion, the brain, the higher the risk of multiple sclerosis, and it can go up to 78% if you have 3 lesions or more. But what we do know right now is that this really does not apply to all optic neuritis, because the study excluded patients who had bilateral optic neuritis, and they probably focused on Caucasian women. So we know that patients from different ethnic backgrounds, let's say Asians or African, they tend to get different types of optic neuritis. So the study findings did not really apply to those. And we now have good serum biomarkers for diseases such as NMO and MOG that the ONTT study really does not apply to those type of optic neuritis. The other thing is with the optic neuritis treatment trial is that the window was only up to 8 days for treatment. So if you look at optic neuritis worldwide, we know that now there's, for example, there's a higher incidence of NMO in Asia and the East, and also in African Americans. And there is a higher incidence of bilateral optic neuritis in Asia. Remember that the optic neuritis treatment trial excluded patients with bilateral optic neuritis. And the other thing is that clinically, in some studies, that 50% of those patients with optic neuritis in Asian study really do not have pain with eye movement. So we know now, because we have new biomarkers for optic neuritis, that we have new phenotypes, namely NMO and MOG, and these type of optic neuritis really follow different pathophysiological mechanism than what we expect to see in demyelinating MS-type optic neuritis. They tend to be more aggressive, and NMO is really a blinding disease. It's not like optic neuritis that whether you treat or you don't treat, the vision will always get better. So early diagnosis is important, and this can be done by obtaining the specific biomarker. And the long-term treatment for NMO is different than MS. You cannot use the same medications. So what they did is that they went back to the optic neuritis treatment trial and tried to find out if there were any participant in the study that had any of these biomarkers. And so out of 177 patients, they only found about 3 who were MOG positive. And if you look at the characteristics of these patients, they all had dyschedema at presentation. They had complete recovery of visual acuity, and none of them were corticosteroid dependent. And none of these patients developed MS even after 15 years of follow-up. 2 patients actually in that study had complete recovery of visual field, and 1 had residual visual field defect. So the way we treat optic neuritis, according to the optic neuritis treatment trial, is by giving the patient IV steroids for 3 to 5 days. Although now there are some studies that suggest oral steroids may be as equally effective. So if you can give the patient 1,250 of oral prednisone or even 500 oral methylprednisolone, this can be as effective as giving them IV steroids. And oral steroids are cheaper, they don't require admission to the hospital, and they're more convenient to use. So when should you suspect atypical optic neuritis, or NMO, or MOG? If you have severe loss of vision, almost 90% of patients at the optic neuritis treatment trial had vision between 20/20 to 20/200. So if you have NLP vision, if you have bilateral disease, if the patient does not improve after 6 weeks, not that you would wait that long before you start treatment, and if they have progressive course, the lack of pain, and if you see atypical findings in the fundus, such as severe dyschedema or hemorrhages. The other thing is that recurrence. Let's say you give the patient steroids and then they relapse immediately once you stop the steroid. This is all signs of an atypical type of optic neuritis. And we now have criteria to diagnose neuromyelitis optica, spectrum disorder. So basically you need at least 1 core characteristic, which is any one of those, one of which is optic neuritis, and you need to have a positive test for the aquaporin 4 immunoglobulin using cell-based assay. So NMO optic neuritis is usually unilateral, can be bilateral, however, and it tends to cause more severe and rapid loss of vision. Females are more affected. You don't tend to see dyschedema in these patients. And just to add to the difficulty that we're facing right now, you might have sometimes clinical overlap between what is typical and what is atypical optic neuritis. So sometimes they don't really present with severe loss of vision as you would expect from NMO, and this is kind of the overlap between NMO and MS optic neuritis. So we now have a cell-based assay. We have a specific biomarker to look at NMO, and it's very specific, 80% sensitive. And sometimes you can get a false negative result. You have to repeat the test maybe after 3 to 6 months. Plus, you could do the lumbar puncture and look at the cells, and you can look at the oligoclonal band, which are uncommon in NMO as opposed to MS. So as far as the neuroimaging findings, MRI of the orbit is really important because back in the days, people were not getting orbital MRI because it doesn't really add to the diagnostic value. We know that it's important to obtain MRI of the orbit, and you want to look at the length of the optic nerve involved. So if you have a long segment, such as in this patient, remember there's more than 50% of segment involved of the optic nerve with enhancement. If you have posterior visual pathway enhancement, if you have chiasmal enhancement or involvement of the posterior part of the optic nerve, this is more suggestive of a neuromyelitis optica. This is another patient. You can see here in the upper left side, there's chiasmal involvement, which is really atypical for MS. You only see that with neuromyelitis optica. As far as the brain lesions for NMO, remember these lesions tend to hang around where there's high aquaporin 4, so they tend to be concentrated in the diencephalon region, the thalamus, the hypothalamus, and around the fourth ventricle. So should you obtain NMO, IgG in every optic neuritis? Some studies have tried to address that question, and they found that the older age of the patient and the lack of disc swelling probably are associated with seropositivity. You might be more likely to get a positive aquaporin 4 assay for these patients. However, again, we will emphasize again that there might be some overlap in what is known as typical versus atypical optic neuritis. And both of these patients, according to some studies, can have equal percentage of seropositivity. So how do we treat NMO optic neuritis? Well, first you treat them just like you treat any optic neuritis. You start the patients on IV steroids, but you taper them slowly because you want to wait for the results of the assay, right? And you have to follow them closely while you are maintaining them on oral steroids. If they don't improve with IV steroids, let's say after a week, then you need to do plasma exchange. And you need to do that early again. You need this early window to get any kind of good visual outcome. And for bilateral cases, you should have a very low threshold of treating this patient. Remember, NMO is a blinding disease. The patient can end up with permanent visual disability if you don't treat them early. So, and there are some studies that looked at that, and they found that the best clinical outcome was with simultaneous IV methylprednisolone and plasma exchange within 2 to 5 days from onset. As far as chronic treatment, you can use immunosuppressives, so you can use azathioprine, rituximab, second-line agents, and also there are some new monoclonal antibodies in the pipeline, and some of them in the market as well, mainly complement inhibitors and interleukin-6 inhibitors for chronic treatment of neuromyelitis optica. And what about MOG, anti-MOG? So MOG tends to be more common in children, and it's an inflammatory demyelinating disease. It can present in children as a syndrome of acute disseminated encephalomyelitis, and about 30% of children with demyelinating disease will be positive for MOG. And you never get both seropositivity for MOG and aquaporin at the same time. So how do you suspect MOG? It tends to be recurrent and bilateral. There tend to be more disc edema in these patients, unlike typical optic neuritis, and they can get disc hemorrhages. Remember, all these features are atypical and were considered atypical for a typical optic neuritis. They tend to respond quickly to steroids, and once you stop steroids, they tend to recur. And vision loss, although more severe at onset, they tend to have a better long-term visual prognosis. So neuroimaging for MOG, again, you would see the same kind of long segment lesion that we saw for NMO, but the additional thing is that here you can have a perineuritis type of picture, which is enhancement of the optic nerve sheath around the optic nerve. This is thought to be a fairly specific sign for NMO optic neuritis. And then the way you treat it, the acute treatment is the same. You can use IV steroids. You can use plasma exchange if they don't improve. And again, plasma exchange works better if you give it early. How about chronic treatment? You can use any of those immunosuppressive agents that we mentioned for NMO. However, there are some studies that suggested actually monthly IV immunoglobulin might be beneficial for these patients. This is just a table to compare the different types and different phenotypes of optic neuritis. So the main thing is that neuroimaging, long segment of the optic nerve sheath, posterior visual pathway, chiasmal involvement is more suggestive of MOG or aquaporin 4, and the distribution of lesions in the brain and MRI also is different. Well, what about pediatric optic neuritis? Pediatric optic neuritis tends to be bilateral, presents with severe disc edema or papillitis, tends to be post-infectious, and pain is often absent in these in the kids. They tend to have the kind of same association with MS. The risk of MS in certain studies was 36% at 2 years, and the risk is higher if they have positive oligoclonal band. Pediatric optic neuritis and NMO. NMO frequently present with isolated optic neuritis without transverse myelitis as opposed to adults. And aquaporin 4 was associated with early recurrence and visual impairment. The pediatric optic neuritis prospective outcome study is a study that is going right now in North America, where they're recruiting patients from 45 sites, and they're trying to determine the ability to enroll patients with optic neuritis in a research protocol and trying to estimate the visual acuity 6 months after the initial presentation of a treatment. So as far as optic neuritis, there are some questions that probably we have not yet addressed. Is what is the optimal dose for steroids for optic neuritis? Some people using 3 grams, some people use 5 grams, some people using 7 grams. Are high-dose steroids and high-dose oral steroids equivalent? Oral steroids are cheaper and easier to administer. Should we use oral steroids instead of IV steroids? What is the effect of delay of initiating steroids on the visual outcome? Does it really make a difference if we treat the patient within a week or 2 weeks later? And what is the role of PLEX? Should we really give plasma exchange to every optic neuritis that does not really improve with steroids? So to summarize, optic neuritis is not a single disease anymore, and the OTT guidelines really apply to only one type of optic neuritis, which is the MS-associated optic neuritis. Well, now we have specific biomarkers that are looking at that have characterized and defined certain phenotypes of optic neuritis, and this will predict the natural history and prognosis and will guide the treatment. Ophthalmologists should have a low threshold for testing for these biomarkers in cases of optic neuritis presenting with atypical features, and early steroids and plasma exchange is important in preventing permanent visual loss, particularly in NMO optic neuritis. Thank you.
Thank you, Dr. Raed. Next, Dr. Dana will talk about neuro-ophthalmic diagnosis, not to miss.
Okay, thanks again. We're going to be talking about neuro-ophthalmic diagnoses, not to miss. I have no financial disclosures. So I hope that by the end of this talk, we all recognize urgent neuro-ophthalmic cases and how to manage them. The one most common cause of death that is common in all these cases is that there is some underlying acute vascular pathology. So let's talk about our first case. This is a 22-year-old young lady who came to me with headaches and pulsatile tinnitus over the past 4 weeks. and she presented with progressive vision loss over a few days. Her vision was 20/20, she was full color, but she did have a right RAPD. Her visual fields showed severe constriction, and she had severe bilateral optic nerve head swelling. So the fact that she had these symptoms, along with the optic nerve head swelling and this vision loss, prompted us to say this is probably papilledema. And because of the severe vision loss, we call this fulminant papilledema. So we all know that papilledema is optic nerve head swelling secondary to high intracranial pressure. The patient can present with symptoms of headaches, pulsatile tinnitus, nausea, and vomiting, and they can present with transient visual obscurations and binocular diplopia or progressive vision loss. They will have bilateral optic nerve head swelling, and they may initially present with a normal afferent system. So they may have full color, full 20/20 vision, no RAPD, and just an enlarged blind spot. But if this was chronic, untreated, or fulminant, it can certainly progress to severe visual loss, and if they wait a little longer, they may even snuff out their central visual acuity to no light perception. So why do we worry about papilledema? Well, we just said that it can cause blindness, but it may also harbor an underlying cause of death. And so the three things that we want to remember when we see a case that we think is papilledema is that malignant hypertension may look like this, and it can cause a hemorrhagic stroke. We need to rule out cerebral venous thrombosis by a venogram study, and we need to rule out a space-occupying lesion with an imaging of some sort. The reason that space-occupying lesions that cause papilledema are dangerous is because they can cause herniation of the medulla and cut off the vascular blood supply to the cardiorespiratory centers in the medulla, causing sudden death. So what happened to our patients? We checked her blood pressure, we asked for a CT and a CTV, they were both normal, and because of her severe progressive vision loss, we admitted her and did an MRI-MRV with contrast, which showed only features of high intracranial pressure, and an LP was done, and the opening pressure hit the roof with 55 centimeters of wire, very, very high, and normal CSF composition. So what's your diagnosis? Idiopathic intracranial hypertension. But because of the severe progressive vision loss over the past few days, we call this fulminant IIH, which constitutes about 2% of all regular IIH. These patients are urgent. You need to admit them, you need to treat them medically, and ultimately a surgical treatment should be done. So the medical treatment includes medication Diamox, 2 to 4 grams a day, but be aware of metabolic acidosis, so follow those patients carefully. Also control the risk factors. So if the patient is anemic with a very low hemoglobin and they need a blood transfusion, for example, you need to control those risk factors. You need to remove any offending agent, such as a medication, for example, and you may or may not give IV steroids, but there's no clear evidence. Ultimately, you need a surgical treatment, and if you cannot do the surgery within 24 to 48 hours, you have to at least ask for a temporary lumbar drain. You have the choice of one of three treatments: optic nerve sheath fenestration, if the vision loss is worse than the headache, a CSF diversion procedure, if there's a severe headache and vision loss, or you can also do a transverse sinus stenting, which has emerging evidence. But keep in mind that if you do choose a stent, the patient will be on a dual antiplatelet therapy, so should the stent fail, nobody wants to touch them from a surgical standpoint. We chose optic nerve sheath fenestration for this patient, and she improved her visual fields to driving vision. So thankfully, this is a happy ending. So the pearls for papilledema is to always check the blood pressure, do a CT, CTV to rule out the causes that can cause high morbidity and mortality. And remember that recognizing fulminant IIH is important. Admit these patients, and ultimately they will need surgery. The next case, the answer is in the. This is an 85-year-old female who presented to us at night to our junior resident with sudden vision loss of her right eye. She had counting finger visions with a right RAPD and a seemingly normal rest of her neuro-ophthalmic exam. Now, her blood pressure was very high. It was 209/108. And because she's 85 and she had the sudden vision loss, she was asked about GCA symptoms, and she had headaches and some jaw claudication. And she had a serology done, which one could argue may be borderline ESR for her age, but a normal CRP, and there was no relative thrombocytosis. So what's going on here? Normal fundus, but sudden vision loss in RAPD. There must be something going on. It's likely ischemic in nature. So is it a posterior ischemic optic neuropathy? Well, it's not anterior because there's no optic nerve head swelling. If it's posterior, then you want to ask yourself, is it arthritic or not arthritic? Any ischemic pathology in the world, that's the first question you want to ask yourself. Is it arthritic or non-arthritic? If it's non-arteritic, these are the cases that usually are post-surgery, there is blood loss, there is hypovolemia. So this patient didn't have any of that. Or is it arteritic? So of course, to check for serology, do a temporal artery biopsy and start on steroids. Or did this patient have a retinal arterial ischemia, but we're still not seeing the changes in the fundus, which can happen sometimes early on. So what do we do if that's the case? Well, two things. Is it arteritic or non-arteritic? And if it's non-arteritic, which is the most common cause for retinal arterial ischemia, that's an emergency because the patient has a higher risk of stroke if you don't optimize the risk factors. So you want to check their blood pressure, you want to check for vasculopathic risk factors. In fact, a study looked at CRAO patients and they found that about 60% of CRAO patients had at least one vasculopathic risk factor that they didn't know about. And the most common one is hypercholesterolemia. You need to do a CT angiogram because the most common cause of a CRAO is carotid disease, and it could be carotid occlusive disease, or it could be carotid just ulcerating disease. You need to start the patient on antiplatelets, and you need, of course, to send them urgently to do a stroke workup. Or is it an arteritic? And we know what to do, serology, biopsy, and steroids. So what happened to our patient? Well, we decided to work them up for non-arteritic and arteritic, and we knew that the answer was going to be in one diagnostic testing, but this was at night, so we didn't have the test. So we brought the patient the next day. We did an OCT of the macula. And as you can see here, there's this hyperreflective band in the internuclear inner plexiform layer. And this is a diagnosis called paracentral acute middle maculopathy. This is a fairly new diagnosis, OCT diagnosis. It was described by Ashraf and his group in 2013. And what it is, it's ischemia of the middle retinal plexus. And this could occur in malignant hypertension. It could occur in different types of vasculitis. It even can occur in young patients, and they call idiopathic. In this patient, we could have chalked it up to malignant hypertension, given her blood pressure was 209/108. But I will tell you the rest of the story. In retrospect, when you look at the fundus, there's these little white spots there that you can see. And these are very subtle findings of the PAM that we see here in the OCT of the macula. So remember, this patient is 85. She had the headache and the jaw claudication. She had a borderline ESR. So we did a temporal artery biopsy, and this was giant cell arteritis. So vision loss in GCA can be transient and can be permanent. If it's transient, consider amaurosis fugax, of course. It could be ciliaretinal artery occlusion, central retinal artery occlusion, anterior ischemic optic neuropathy, could be ocular ischemic syndrome. It could be a visual field deficit from strokes, mostly posterior circulation strokes. But you can add to your list PAM as a cause for vision loss in GCA. So whenever you have ischemia of any sort, ask yourself, is it arteritic or non-arteritic? If it's arteritic, ischemic, or retinal, then do the serology biopsy and steroids. And if it's non-arteritic retinal ischemia, do the stroke workup, because you have a role in reducing the risk of a recurrent TIA or a stroke by 80% should they optimize their risk factors. Next case. This is a patient who came to me in the clinic with a headache to rule out GCA. This was a 68-year-old man. When a patient comes to me in my eye clinic with a headache, I don't know all the causes of headache in the world, but I know what I need to know. So I have an algorithm. Is the headache coming from the eye? Is it coming from the orbit? Or is it a systemic cause of headache? So things from the eye you'll see, obviously, like scleritis or something like that. People tend to forget shingles before the rash or intermittent angle closure glaucoma. When it's the orbit, again, you'll see orbital features such as cellulitis, orbital inflammatory syndrome. The one that we forget here is trochleitis, so Churchill's trochleus. And systemic causes are the causes that may cause death. So this is the malignant hypertension, GCA, high ICP, Horner syndrome, third nerve palsy, neurological visual field deficits, and diplopia, which may indicate a pituitary apoplexy. Of course, a history of malignancy, trauma, and also because I know about migraines and trigeminal autonomic cephalalgia, I will ask about those. So these are the things that if I ask about and examine for, I would then sleep, soundly at night knowing that I did not miss an important diagnosis. So this patient had a very, very subtle anisocoria, and the patient did not even know about it. The anisocoria was worse in the dark, and so you would want to consider a Horner syndrome. This patient had a dilation lag on examination. With a Horner, you can have reversal of anisocoria with the aproclonidine, and you can have a persistence of 1 millimeter or more of anisocoria post-cocaine. So how do you diagnose or localize a Horner? Well, really clinically. So with the associated features that come with a Horner. Is it coming from the brainstem? Is it coming from, the chest, smoker, Pancoast tumor? Or is it coming from the, a cavernous sinus? In this case, you want to make sure that if it was a painful Horner, then, or at the acute Horner, you want to rule out a carotid dissection with doing a CT angio of the head and neck. And if there's a high suspicion, also do an MRI because sometimes it's missed on a CT angio. This patient had a left carotid dissection. He was treated. The headache improved, but the Horner persisted. Okay, so painful Horner is a carotid dissection. Do your vascular imaging. This is a case. I don't know if I can play this. Okay. This is a case that was sent from the emergency department to our resident. She was sent for cellulitis, but there's nothing really cellulite about her. Like, she has left complete ptosis. She has a non-pharmacological dilated pupil. She has complete duction deficit, a supraduction deficit, and infraduction deficit, which indicates that this was a left complete pupil sparing isolated third nerve palsy with no aberrant regeneration. Did you guys see? Pupil dilated? Yeah. Non-pharmacologically dilated pupil involving third nerve. Did I say pupil sparing? Oh, sorry. I meant pupil involving. Definitely. Okay. So that's a trick, so you're awake with me. All right, the 3 things to learn about the third. Rule out a PCOM aneurysm with a CT angiogram, okay, of the head and neck. Rule out GCA in the right context. And once you rule those things out, then you consider about other pathologies. The third thing that I like to add here would be something that causes a pupil sparing and a painless third nerve. Only after you've ruled out the first 2 is myasthenia gravis, because it can look like a third nerve. Now, whether it's pupil sparing or pupil involving, by the way, the inclination is to image all comers of third nerve palsies, because up to 13% of pupil sparing third nerve palsies turn out to have a PCOM aneurysm or some compressive etiology. So what happened to our patient? She had a left PCOM aneurysm. She was admitted that night. Neurosurgery did their job and they clipped it, and this patient is forever grateful for our resident for saving her life. Okay, our last case. A 44-year-old man comes into our emergency eye clinic, and they present to our resident with saying that, oh, my vision in the right eye is not really good. The resident takes a look, does a full neuro-ophthalmic exam, and the only thing that the resident could catch is that the patient had 20/30 vision in their eye, in the right eye, but nothing really else. The resident told the patient, well, come next week, we will do diagnostic testing, we'll have visual fields, we'll have OCTs, let's see what's going on. So they come back the next week, that's when I saw them. And that the patient now is 20/60 in the right eye. He has a right RAPD and a concomitant small exotropia. This patient on visual field testing had a right junctional scotoma. So now you know, with this headache and this, rapid onset or rapid progression of vision loss, that there's something scary going on there. So when you have something that is progressively getting worse and fast, that localizes to the sella, the one thing that you want to rule out is some acute vascular pathology. So what is an acute vascular pathology within the sellar region? Well, is it an aneurysm of the ICA or is it a pituitary apoplexy? This patient had a very rapidly growing pituitary adenoma, okay? And although it didn't look like hemorrhagic on the imaging, it was going to progress into a pituitary apoplexy if it waited a few days, which can kill the patient. This patient was admitted that night and resected. My neurosurgery and the visual field thankfully improved. So pituitary apoplexy is either infarction or hemorrhage into a pituitary macroadenoma. It's a triad of vision loss, headaches, and severe ophthalmoplegia. They require urgent neuroimaging, and remember that steroids can be life-saving in these patients. So in conclusion, remember the cases not to miss in neuro-ophthalmology. Papilledema, is it malignant hypertension, a lesion, or fulminant IH, or cerebral venous thrombosis? Painful Horner is a carotid dissection. Arterial occlusion, is it arthritic or non-arthritic? A third nerve palsy, is it a PCOM or GCA? And pituitary apoplexy, don't forget your triad, headaches, ophthalmoplegia, and vision loss. Thank you.
Thank you, Dr. Dana. Next, Dr. Raed will be talking about OCT in neuro-ophthalmology.
Okay. So those of you who have been here early today, they probably listened to lectures about OCT and glaucoma. They never think about OCT in neuro-ophthalmology. Actually, there's a huge role for OCT in neuro-ophthalmology right now. And if you think what happens to the optic nerve, it either can swell, it can atrophy, right? And this is what we use the OCT for, is to monitor changes in the optic nerve. And because we're neuro-ophthalmologists and we're not necessarily getting neuro-ophthalmic diseases, we might get other diseases such as retinal diseases and maculopathies. We use the OCT to differentiate these diseases from neuro-ophthalmic disorders. So these are probably one of the two most common machines, and the retinal fiber analysis that you would see, the spectralis machine, and on the left side, and the Cirrus machine, the spectralis and the Cirrus machine. But more importantly now, there's a growing role for measuring the ganglion cell layer, specifically looking for optic neuropathies. And again, this is the spectralis, OCT at the top, and Cirrus at the bottom. So if you think of optic neuritis, what happens with the nerve fiber layer initially, of course it swells, and this can be not really informative at the beginning because it doesn't really give us any information. But what happens is that within 3 to maybe up to 6 months, the thinning tends to plateaus, and we don't really see thinning beyond that. This is from the study by Fiona Costello. So this is the point where probably that you don't see further loss of the nerve fiber layer. And this is an RFL analysis from patients with optic neuritis, and there is a tendency for the temporal quadrant to be involved with optic neuritis, and you would see thinning of the temporal quadrants and the maculopapular bundle. And you can notice here that although there's thinning of the OCT, the visual field looks absolutely normal. So there's temporal thinning actually in both sides, and this is the maculopapular bundle. So the advantage of having the ganglion cell layer analysis is that it's really not even affected by the initial swelling that you would see with of the nerve fiber layer, right? So you can actually monitor ganglion cell loss very early on in the course of optic neuritis. And this can start within a week or two following optic neuritis. During that time, you will have just nerve fiber layer swelling if you just use the nerve fiber layer analysis. And this is a ganglion cell layer analysis showing loss of ganglion cell layer on the left side, already developing in this patient with optic neuritis. Again, this is another example of RNFL loss in optic neuritis, and you can notice that there's propensity for the temporal quadrants to be involved. And this is a patient with optic neuritis, and you can see that there is loss of the ganglion cell layer. So the red indicates kind of healthy, if you like. So loss of red around the macular indicates thinning of the ganglion cell layer. And this is just to show you the progression of the ganglion cell layer change in a patient with optic neuritis. So right from the onset, right from the get-go, where the nerve fiber layer looks normal, you're already seeing ganglion cell layer right on the onset, and this tends to be stable even after 3 to 6 months. With that, you can get probably more progressive thinning of the nerve fiber layer. So the ganglion cell will precede RNFL layer changes by at least a few months. And we now use OCT for multiple sclerosis because patients with multiple sclerosis, even if they don't have history of optic neuritis, they will have thinning of the nerve fiber layer and the ganglion cell layer, and they will have more rapid progression of this thinning than normal people. So you can actually use the OCT to screen for this patient as an adjunctive tool to help the neurologist for the diagnosis of multiple sclerosis. Recently, we've started using OCT to differentiate different types of optic neuritis, so we can try to differentiate NMO optic neuritis from typical MS optic neuritis. And generally speaking, retinal nerve fiber layer loss tends to be more severe, more significantly worse in NMO than optic neuritis. There are some studies that showed that if you lose about 41 microns of thickness, this is almost 100% specific for NMO. Remember, with a typical optic neuritis, you lose about 10, maybe 15 microns. The NFL loss tends to be more diffuse in NMO, while in MS, optic neuritis tend to be more temporal, and I can show you some, this picture will show you that on the left side you have NMO. You can notice that there is more diffuse loss. It's not just the temporal quadrant, it tends to be all over the optic nerve head, and there's even more loss of the ganglion cell layer in NMO than in MS optic neuritis. The other use for OCT is that patients with MS can be on different treatments. One of them is fingolimod, and fingolimod has been associated with macular edema. So we can use OCT to screen for patients who have fingolimod-associated macular edema. It looks exactly like what you see with diabetic macular edema, and you can see these cystic changes of the internuclear layer. Once you stop the treatment, the edema goes away, and generally speaking, there's a recommendation to have a baseline and follow-up OCT for these patients. What about in papilledema? So there is a role for OCT in papilledema right now, and you can actually use the neurofibrillary therapy not as much as to diagnose papilledema, because we know that the quantitative measurements, just measuring the nerve fiber layer, does not really differentiate papilledema from pseudopapilledema. But it's more helpful to monitor changes in the nerve fiber layer in someone who has established papilledema. And this, so this can help you actually in sort of trying to determine whether this patient is improving, and it can actually guide your treatment. Remember, improvement in the nerve fiber layer thickness doesn't really necessarily implies improvement. It can also implies optic atrophy and loss of the nerve fiber layer. So this is someone with a patient with idiopathic intracranial hypertension, and you can see there's disc edema and there's thickening of the nerve fiber layer. And you can even see on the transverse scan, OCT scan, that there is sort of this dome-shaped, like bilateral humped, dome-shaped elevation of the optic nerve. And this is someone who actually had unilateral asymmetric papilledema, which is relatively rare. And you can see that from baseline that there's nerve fiber layer thickening, and with treatment, once you put this patient on treatment, you give them Diamox, the retinal nerve fiber layer thickness goes back to normal. This is someone with the IIH as well, and you can see at the top that there is thickening of the nerve fiber layer on the left side, and with treatment, the nerve fiber layer thickness sort of decreases. But you kind of notice here, if you look at the upper left side, that there was an enlarged blind spot at the beginning on the left side. The enlargement of the blind spot disappears, goes back to normal, but you still have a residual kind of nasal visual field defect. So this is just to reemphasize the point that improvement in RNFL thickness doesn't usually implies improvement in vision. It could just implies optic atrophy. Now, we have to be careful with patients with severe papilledema, because often at this stage the segmentation algorithm fail and you can get segmentation errors. So the segmentation is the line that is supposed to be aligned with different specific layers of the retina, and at this point you cannot really rely on this algorithm to measure the retinal nerve fiber layer thickness. So people have started looking into more of a qualitative measures in the OCT, not more quantitative, and using transverse OCT, you can look at the way the optic nerve head is deformed with increased intracranial pressure. And if you look here, this is the terminal RAP and Brooks membrane. What happens with papilledema with increased intracranial pressure? It tends to be angled, it will be angled inwards. So we'll have sort of negative angulation of this layer. And you can see that in the OCT of this patient. At the top, this patient, to begin with, had papilledema, so you can see the kind of upward negative angulation of the RPE and Brooks membrane, and with normalization of the intracranial pressure, it will go back into the normal kind of V-shaped like configuration in normal individuals. So this is one example of using the qualitative measure of parameter of the OCT to diagnose and monitor papilledema. In patients who have chronic papilledema, they have optic atrophy, so the nerve cannot really swell anymore. So you're going to have to rely on the ganglion cell layer to monitor progression of their disease. This is someone who had chronic papilledema, but as you can see here, he does have a robust ganglion cell layer, and there's no thinning of the ganglion cell, or at least not yet. This is someone with papilledema, and you can see the nerve fiber layer thickness. At the top, there's thickening of the nerve fiber layer on the right side, and there's ganglion cell layer loss in the deviation map at the bottom. What about optic nerve head drusen? So this is one of those things that especially residents get confused. Is this papilledema? Is this not papilledema? How do we differentiate papilledema from pseudopapilledema? How do we diagnose optic nerve drusen? So optic nerve drusen is a very common cause for anomalous disc. It tends to occur in about 2% of the population. And the drusen can be superficial or can be buried and not really seen. So the Optic Disc Drusen Studies Consortium have established certain criteria to diagnose drusen by using enhanced depth imaging. So a drusen will have a hyperreflective core with a hyperreflective margin. And you need to differentiate those, for example, from blood vessels, as you can see here with the kind of figure of 8 configuration. So this is one area where you should not really be confusing the two of them, right? So this is an optic disc drusen. You can see a hyporeflective core and a hyperreflective margin. Foams is basically hyperreflective ovoid-like masses that occurs in the peripapillary region, and they are thought to be some kind of a precursor or variant of optic disc drusen. They're really not specific for optic disc drusen, and they can be found in different types of optic neuropathies. This is just a case, a 22-year-old with right sudden loss of vision, treated with IV steroids as optic neuritis, no improvement. 5 months later, had loss of vision in the left side, maternal cousin with labor, so family history of labor already, visual acuity 2400, 400 and 2200. This is the visual field, and you can see here that the fundus photo, there's already some temporal, so there's some atrophy starting to develop on the left side, maybe some hint of telangiectasia, swelling on the right side. Patient has a left visual field deficit. And this is the ganglion cell analysis showing you loss of the ganglion cell layer of this patient on both sides. You can see the similar pattern in any kind of toxic optic neuropathy and labor optic neuropathy, that the thinning tends to be on the maculopapular bundle, and at the bottom here you can see that there is loss of the ganglion cell layer as well. What about compressive optic neuropathy? And Dr. AlBreiki already alluded to that in her talk. You can actually use the OCT to predict the visual outcome of patients who are undergoing surgery to remove pituitary tumors or various compressive lesions. So the healthier the RNFL or the GCL, the better is the visual, expected visual outcome. And the other thing is that the OCT here can be localizing just like the visual field. So the pattern of RNFL and GCL loss can really help you in localizing this lesion, the lesion. So binasal thinning, for example, you expect that with chiasmal lesions, and homonymous, you would see that with retrochiasmal lesions. So this is a patient with a pituitary tumor And you can see here that there's sort of, it's not really binasal. It doesn't really respect the vertical midline, but you kind of get that flavor as well. And you get the bitemporal hemianopsia. This is another patient with a pituitary tumor, pre-op at the top, bitemporal visual field defect, and a binasal loss of the ganglion cell layer. Post-operatively, although the visual field improved, the ganglion cell layer analysis did not really improve much. So this is just show you the dissociation between structure and function, if you like, between visual field and OCT. This is another patient with a meningioma. Now, despite having a normal visual field, she has already lost, she has thinning of the nerve fiber layer, and she has loss of the ganglion cell layer on the left side. What about retrochiasmal lesions? This is a patient with a stroke on the left, and with the right homonymous hemianopsia. And you can see here there's a homonymous type of ganglion cell loss. So again, the OCT can also be of localizing value, just like the visual field for localizing where the lesion is. What about non-optic nerve diseases? So because we get referred, we always get referrals for different kind of diseases, and some of these disorders may not be necessarily neuro-ophthalmic. The most common non-optic nerve diseases that we see are either subtle maculopathies, so these can be inherited retinal degeneration or maculopathies, epiretinal membrane, inflammatory disorders of the retina such as MUDES or acute macular neuroretinopathy. And in these patients, it's always helpful to look at the outer retina, specifically that ellipsoid zone, the inner segment, outer segments junction, and look for any kind of irregularities or loss, just to indicate that this is an outer retinal disease, not really an optic nerve disease. This is a case that I saw recently. A 43-year-old presented with 2-week history of sudden onset of visual loss in the right eye, and 7 months ago she was diagnosed with MS actually, and was started on treatment. So the neurologist thought she had optic neuritis, and he wanted to treat her with steroids. She was recently received the AstraZeneca COVID vaccine. Her vision was 20/40 and 20/30, full color vision, no afferent. She did have motomorphopsia using the Amsel-Grid test on the right side. And if you look at the fundus here, you can see these kind of like halo, hypopigmented type of lesions around the fovea. So something was going on there in the macula or the fovea. And if you did it in OCT, and she had this kind of focal-like elevation of the RPE and the outer retinal layers, and this was in both sides, so it's the top, the right, and the bottom was the left. So she probably had some kind of acute retinal pigment epitheliitis or some kind of inflammatory diseases of the retina. And we did OCT scans 3 to 6 months. There has been no change in the lesion. So OCT here was helpful in kind of not to subject her to IV steroids and the whole consequences of events that will probably lead to misdiagnosis. So in summary, OCT is a non-invasive, highly reproducible tool to assess disc swelling or atrophy in optic neuropathies. It can help diagnose even patients who have MS and asymptomatic early in their disease course. And the ganglion cell layer is a very useful adjunctive test to monitor the progression of optic neuropathies. OCT can help you also diagnose papilledema, disc drusen, and follow up patients with IIH. And it's also helpful to differentiate optic neuropathies from non-optic nerve diseases which can present with visual loss. Thank you.
Thank you. And with that, we're done with this, the last lecture of this session. If anyone has any energy to ask any questions, you'll feel free to ask our speakers. We have a question there.
Yeah, thank you. Just a quick question regarding the last talk. How often do you see OCT findings in patients who have post-chiasmal lesions?
Sorry, what was the question?
How often do you see changes in the retinal ganglion cell layer on OCT in post-chiasmal lesions?
So you're saying transsynaptic degeneration
That's correct,
finding.
yes.
We've seen that in a few cases, patients are presenting with strokes and have had sort of homonymous visual field defects.
So are you expecting to see that in a patient with a posterior stroke?
I don't expect to see that in adults because transsynaptic degeneration classically thought to occur only in children. But we do see some of these cases, and I don't know why some patients develop it and some do not develop it.
Because you were describing it in an adult just now.
Yes, yeah.
But you don't expect it to usually happen.
I just don't know who's the patient who's going to develop it and who not. But we do see it, and it has been described and reported. Yes.
Yeah, I would also like to add to that. I mean, I have seen it, but it happens years later. You can see it actually. There have been case reports, and I've actually had a case in which I've done OCT, and it did show ganglion cell loss. Like he had like a stroke, and this was 3 years before. So it can happen if you look for it.
I don't think we know the answer as to who's going to get it, but I'm sure it has to do with some extent of the lesion as well and how long it's been there. But we do definitely know now that there is some transsynaptic degeneration.
We see it in children all the time.
Yeah, but we do see it in adults for sure.
Thank you.
Yeah.
Other signs, no signs, only ganglion cell layer. Do we need to do any further investigations, neurological, I mean?
So this is a question for you. Okay, you can answer if you. Okay, well,
because I find it so often.
So you mean binocular diplopia?
No, not diplopia. It's in the OCT. Ganglion cell layer deficit or thinning. The patient has no other signs, only this, with drop of vision, of course.
I don't know. I mean, you probably have to consider the age of the patient as well.
Older age group.
I mean, the first thing that I would think of is probably glaucoma, right?
No, not glaucomatous. Yeah. Definitely.
You probably have to look at the OCT. You have to make sure the OCT, the quality of the OCT is of adequate, sufficient quality.
It is.
Whether if it's asymptomatic, if the patient is asymptomatic, whether you should go ahead and probably investigate. I would certainly probably ask more questions to the patient, and particularly inquire about possibility of glaucoma in these patients. I would probably do visual field as well, test color vision. So you do the most comprehensive, the most thorough examination you can do. And if the patient if all of that doesn't really yield much, I'm not sure what's the answer.
The scenario is, for example, a regular patient coming to my clinic, and when I examine the vision, I see it's 20, 30, 20, 40, best corrected. With no corneal affection, no lens opacity, no retinal affection, nothing. Pupil is good, color vision is good. So I do OCT. I find this, but I need to do further to go for visual field to do everything?
I think I would ask them in the history if they experienced sudden loss of vision probably previously, and they haven't really pursued. They haven't seen a doctor. The most common thing probably is you think of as an old ischemic optic neuropathy or kind of an old ischemic event, and it's helpful when you do the OCT also just as Dr. Dana showed, to look at the inner retinal layers as well. many of these patients would have events and they could be asymptomatic. So in our clinic, the most common is ischemic, old ischemic optic neuropathy. It's only after they had vision loss in the left eye that they become symptomatic and they come in for, but again, if I see optic atrophy, I probably would scan the patient as well just to make sure I'm not missing anything. Yeah, so it all depends on the history and the presentation.
Are you talking about a unilateral process here? It's a bilateral process? Yeah. Well, I mean, I think a visual field is very important. Like if you have 20/30 vision that you cannot refract to better, and you have thinning of the GCIPL, you don't have complete story unless you have a field. So you have to have a visual field done. They may have a central scotoma, whatever. I mean, it will tell you more, give you more information. You're stuck with this case now. Yeah. Yeah. But when you did the GCIPL, you did it for a reason, because you couldn't get the vision, right? So there must be something else that can give you more information, right? So I think a visual field is definitely something that could be helpful for you.
Yeah, I have one more question. This one is for Dr. Dana. It was an interesting case you showed with the 85-year-old woman with paracentral middle maculopathy who you ended up diagnosing with giant cell arteritis. We see the paracentral middle maculopathy in young patients, often with migraines, females. If you have a patient presenting with that, visual loss with that, and you find that on the OCT, are you suggesting that we need to do a vascular workup for those patients?
I am, but I will tell you that it has been described in young women, especially, that is idiopathic. But you may anticipate that your workup will be negative, but in the end, it is a vascular etiology. So you have to treat it as a vascular problem.
Those vessels are so small. I mean, that's not the vessels that are affected in GCA.
That is very true, but the idea is that there is some watershed zone there. There may have been some, lack of blood flow rather than an actual, occlusive process there. You know what I mean? And it has been described in GCA more often than we think, actually. So there was a paper that looked at PAM in GCA, and they found about 16% of those cases, and I think they had, I can't remember the number, about 50 or 60 cases of GCA with vascular pathology, and they found that they found it more often than expected. And to be honest with you, I've been observing it more, and I see a lot of GCA patients, and I'm seeing it more and more now that I'm doing OCT maculas on all these patients.
I can understand a GCA patient having it, but a young patient coming in and with a presenting sign of that.
I wouldn't look for GCA in a young patient, but it has been described in other vasculitic processes. Of course, in isolation, it would be unusual. Like usually the patient will have symptoms or some other systemic issues, so review of systems is good. But if there's nothing else except this, I would say that it's probably extremely rare to have this. Although there was a recent paper actually that described PAM as the initial presentation of granulomatosis of polyangiitis, so beginner's disease. So again, it's been described. So I think thorough history, whenever you don't know, you have to be careful to call something idiopathic before you do some kind of workup, unless you're comfortable with this completely, right? So there must be a reason for it.
I understand 100% when you have it in the context of other things, but in isolation in a young patient,
I agree.
I find it difficult too. Yeah.
I agree with you.
I have a question, actually. This is a question I get asked often by the residents. When do you do ESR and CRP, or would you do for asymptomatic NIN patient?
That's a great question, and that really all goes back to the definition of occult GCA, right? So the occult GCA has either a clinically occult GCA definition or a serologically occult. Clinically occult GCA is defined as a visual symptom, whether transient or permanent or sign, but with no symptoms whatsoever of GCA, and the patient has a positive biopsy. Usually these patients have high serology, albeit it is lower than their symptomatic counterparts. So that's clinically occult. Serologically occult is the patient who has symptoms, whether visual or usually systemic symptoms, may or may not have visual with those. They will have normal serology and a biopsy that is positive. So there must be something that is going to direct you to look for the GCA. So I'll give you an example. I have a patient who was sent to me for NAION. So I always ask myself, in any neuro-ophthalmic case, what is atypical about this case that's going to make me think that this is not what I think it is? So the patient was sent to me for NAION. He was 90 years old. He had light perception vision, and he had pallid edema. 3 things that are completely atypical, although this patient had no symptoms of GCA and was serologically normal. So he has doubly occult, you know? So we started him on IV steroids and did a biopsy, and that was positive for GCA. Another case is the case that I presented, which is a case of bilateral. Honestly, I thought it was a bilateral sequential NAION, but it healed with cupping. So it was very strange that it did. And so I thought, let's just do a biopsy. And indeed, it was another occult GCA. So there must be something that is atypical about the case, you know, that will push you to look for GCA, right? What do you think?
No, it's just we don't really see as much GCA here as you probably do in Canada. But yeah, like I said, one thing that I noticed is this tendency to get this cupping, which you don't see with the non-ischemic. The other thing is that there's the posterior ischemic optic neuropathy is more common, I think, in giant cell arteritis than it's probably thought to be. So whenever you see someone like the patient you presented with loss of vision and the disc looks normal, you got to get an OCT as well, but you need to think of giant cell arteritis as well. Sure. So differential.
Any other?
I have a question for Dana. Do you get these biomarkers for NMO and MOG for every optic neuritis? So what is your approach? Someone comes with optic neuritis and you get an MRI, so how do you proceed from there?
I personally do, and I think this is a question that is answered depending on who you ask, but I will get the MOG and NMO because I always, most of the time, I look for something that is atypical. Because it's very, very difficult to be super confident that this is such a typical optic neuritis. For me, even a family history of lupus makes this atypical, for example. You know what I mean? So I would get the NMO and MOG, and also I will try to get the MRI orbits quickly because I also, even if the patient, let's say, presents typically from a clinical standpoint, if I see on the MRI orbits that it's a longer enhancement or extending beyond 50%, or there's a perineuritis, or it's a posterior involvement, this all turns it into an atypical optic neuritis. So I do NMO and MOG on, I would say, most of my cases, unless the patient came to me already resolved, and the nerve looks like that of, idiopathic or MS, then that I would say, you know what, if it behaves differently, then I would go for that, but it looks like it's self-resolving, it went back to normal, and the MRI was normal otherwise, or there was, of course, demyelinating plaques looking at MS, then I wouldn't. Yeah, but otherwise I would.
Yeah, I mean, it's just to emphasize this overlap, this clinical overlap. And even the term typical, atypical, I think there's a recent editorial in the Journal of Neurology that is discouraging this use, that's typical versus atypical. And you should deal with it as an optic neuritis. So you should have a really low threshold for obtaining the biomarkers.
And the other thing is about, you had mentioned NMO, and if I suspect NMO from the get-go, for a history of transverse myelitis, persistent hiccups, persistent nausea, vomiting, I would actually start them on the IV steroids and also on the Plex.
At the same time?
If I'm having a high suspicion. Because, as you mentioned, it is a better outcome.
Okay. I think we're done for today. I would like to thank our speakers. I would like to thank everyone who has stayed back at this time. And we are done with today's session. And hopefully, inshallah, we'll see you all tomorrow. Thank you, everyone.